66th annual update in anesthesiology for the opportunity to present. Let's see, by way of disclosures, I have a few. I've received support in some form or another from all of these entities, but I don't think any of them will influence what I have to say today. In terms of objectives, I'd like to talk about the following. Basic features of raw EEG waveforms and their clinical implications. Processed EEG to guide anesthesia in selected clinical scenarios, 5 of them. And recent literature on processed EEG and detecting awareness, minimizing postoperative delirium and cognitive dysfunction if we get enough time to mortality, predicting mortality. So let's start with the basics. In terms of the signal origin, and a big shout out to EEG for Anesthesia at RAFs.org. Most of these figures came from there. They got some really nice content, and thanks to Jake Connell who helped me collect and get these put together. So we've got all these various neurons, and they have electrochemical signals going down their axons, and they create these extracellular potentials or electric fields. And when you get a group of them, each one of them creates its own little signal. And when you put them together, they create a local field potential that we can measure at the scalp. So we put a little scalp electrode on here, and then we've got our axons here from our neurons, and they're creating their little extracellular potentials. And interestingly enough, that the pyramidal neurons in the cortex, a lot of them are uniformly oriented perpendicular to the skull, and they allow us to detect them through the skull. So we put this electrode on there, and we measure and see what we get, and this is what we get. We get a raw EEG waveform that is frequently or commonly described with terms such as frequency and amplitude. We're going to take a deeper dive into that. One of the ways we describe the raw EEG waveform with frequencies is to break them out into component frequencies. If we were to add all these sine waves up, we would get this resulting waveform. And in terms of nomenclature, frequency is characterized in hertz or cycles per second. And in this example, we've got some slow frequency waves, some mid-range, and some fast ones that, when we add them together, might result in a wave like this. Then there's also amplitudes. For example, a given waveform may have low amplitudes, moderate, or high amplitudes. And amplitudes are usually characterized with the word power. So just to review what we saw there, frequencies are described using cycles per second or hertz. Amplitudes are described using power. Power is the amplitude squared, and it's reported in decibels. And decibels is a logarithmic scale that allows us to compare really small signals next to really big ones, all on the same display, where you can see them both. I know what you're thinking. So what? How does this help the clinician figure out what to do? And that, I think, has been a criticism of process EEG monitoring for a very long time. And I'd like to circle back around to this so what as we move along. Let's go back to some of the nuts and bolts here. I mentioned that we could describe the raw EEG if we broke it out into different sets of waves, that if you added up all those waves, you'd get the raw EEG. Well, this is a figure that illustrates how that's done. It uses some math stuff, fast Fourier transform, to decompose the raw EEG into various frequency bins. So we have delta, 1 to 4 hertz, theta, 4 to 8, alpha, 8 to 12, beta, 12 to 25 hertz, and gamma, 25 and above hertz. So you add all these up, you'd end up with this waveform. To summarize there, here are the frequencies for these various bands. I've got alpha highlighted here because we're going to spend some time talking about alpha. Turns out this might be really important. Another feature to the EEG is once you get a bandwidth, say that alpha bandwidth, 8 to 12 hertz, you can notice that the frequency stays the same, but the amplitude varies over time. And that's called an oscillation. So we have amplitude oscillations. So again, those can be used to describe the EEG behavior. Here are some EEG profiles that I recommend everybody just know. They're pretty basic and straightforward. The first one is be able to recognize an raw EEG of somebody who is awake. And its details are it's got higher frequencies and lower amplitudes. And the brain is really going. There's a lot of activity in there. At a surgical level, you see the waves slow down, frequencies are lower, and the amplitudes are higher. And some suggest that the brain waves are more synchronized. So I think it's important to be able to differentiate an awake raw EEG from somebody who's unconscious. Then there's burst suppression, and burst suppression is periods of high frequency electrical activity interspersed by almost no activity, isoelectricity, and then another burst, and then more isoelectricity. This is known as burst suppression. Again, I think this is detectable with with our eye if we just look at the raw EEG waveform. And the final one I think that we should be able to differentiate is isoelectricity. This is asystole of the brain, if you will. So to summarize, I think we should be able to differentiate awake from unconscious, from burst suppression, from isoelectricity. And these are the profiles I think you should know. Again, awake has fast frequencies, low amplitudes. General anesthesia, slower frequencies, large amplitudes. And here's something interesting. The appearance may vary with anesthetic type. Burst suppression, periods of no electrical activity, interspersed with bursts of electrical activity. Isoelectricity, flat line. Could be seen with an anesthetic coma or profound hypothermia. Here's something interesting. Getting back to that burst suppression, it's often presented on, it's presented on EEG monitors using the term SR, suppression ratio. That's a ratio from a 0 to 100. In this particular instance, it's 0. To be honest, I think this is where you want to live. You don't want to be dosing your anesthetic so much that your suppression ratio is greater than 0. More on this later. I'm just going to take a little digression here and talk about this indice here, the PSI, in this case for this monitor. Most process EEG monitors provide an index. Indices are somewhat challenging for clinicians to use because they're stochastic instead of deterministic. And what I mean by that is they're predictive. They're not an absolute measurement. Not only that, they are usually a black box. The technology used to generate the index is proprietary. And they usually require 15 to 30 seconds to calculate. And so there is a lag time. And that lag time can sometimes be clinically evident, especially during times when an anesthetic is changing quickly, for example, during induction and emergence. But in near steady state conditions, they can be a useful tool to summarize what's been going on in the raw EEG. I'd like to discuss some of the figures presented in this paper that came out 6 years ago by Dr. Purdon and company, a group headed up by Emory Brown. And they've really been thought leaders and groundbreakers in process EEG monitoring. And this was entitled Clinical Electroencephalography for Anesthesiologists, Part 1, Background and Basic Signatures. And one of the figures they have, I'd like to show here, I think it's really interesting to orient everybody. They're highlighting the thalamus and the frontal cortex. And they are superimposing a raw EEG of somebody who's asleep with anesthesia and one where they're awake. And they depict there's this activity that goes on between the cortex and the thalamus, and the activity changes going from awake to general anesthesia. And they suggest that most of this activity that's going on between here and here is in that alpha band, 8 to 12 hertz. Oh, let me go back. It is of particular interest. It seems to change with general anesthesia and age. It is thalamocortical electrical activity. The thalamus is thought to integrate sensory information, synchronizing cortical regions with one another. It's been suggested that the electrical activity here may be a biomarker of brain health. And alpha band oscillations play a role in information processing, attention, and orientation. So this seems like a piece of information anesthesiologists may be interested in. If we take a look at the spectral analysis, and we look at amplitude by frequency, we might come up with the following plot. So this is that same figures from before that broke out the different frequency bins of the raw EEG. And let's assume that we're able to measure the amplitude of each one of these frequency bins, from delta all the way to gamma. And then we were to plot that frequency versus amplitude on a figure like this. So we'd have the amplitudes from the gamma wave out here at higher frequencies. Here's the beta waves in this window. so on and so forth for the alpha, theta, and delta. And so here we get a frequency profile in terms of amplitude. Again, I know what you're thinking. What has this got to do with me taking care of a patient? And my hope is that I can drive that home a little bit today on why you care about this and why you want to know this. Here's an interesting thing. There's one term that we can look at on this plot called spectral edge frequency. And it's the frequency where if you took the area under this curve right here, you said, where is 95% of the area? Well, at this frequency and to the left is 95% of the area. This is interesting because it's presented on most process EEG displays. It's right there. This one, for example, is spectral edge frequency left hemisphere, spectral edge frequency right hemisphere. And so this is saying at 11.2 hertz, 95% of the frequency versus amplitude power is below 11. What is also interesting is that these numbers tend to track what this is doing. So this is a measure that doesn't go through any black box. It's just what the brain's doing, and it can give you a feel for, the changes can give you a feel for what your anesthetic is doing to the brain electrical activity. Taking this one step further, let's assume we prepare a frequency versus amplitude plot at time 0, time 1, time 2, time 3, time 4, etc., 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 every couple of seconds. And then we plot these side by side. We get this waterfall plot looking thing. Let's take a closer look at that. So the waterfall plot has on this axis time. So here, that's that first spectral profile we did. And here's one 5 minutes later. And here's one 25 minutes later, so on and so forth. And these are plots over time that are in terms of the frequency and the power. Of note, the power goes essentially from minus 40 to about 20 dBs. And cooler colors usually indicate low power, and warmer colors mean more power. Well, on this spectral display, we can see that there's our gamma band, our beta band, alpha, theta, delta. I know what you're thinking. You're going, why are you boring me with this stuff? I'm going to try to get there, and hopefully this will be useful to you in a clinical sense. We can transition this three-dimensional plot to a two-dimensional plot where the horizontal axis is time. This left vertical axis gives you the frequencies, and this axis over here shows you the power from the cool, low frequency, cool, low power, warm, high power color scheme. And we can map out the different frequency bands, theta, theta, alpha, beta, and gamma, as we're looking across our spectral display over the last, in this case, half an hour. Some interesting things about this spectral display is that different drugs look differently on this. That's a nuance that folks have been able to discover looking at different drugs. They also vary by age. They're typically presented as two spectral displays, one for the left side and one for the right side, and they're flipped. In other words, the frequency here goes from 0 to, this case, 40 hertz, and then 0 down to 40 hertz. 0 up to 40 hertz, 0 down. over time. This is the right side of the brain, this is the left side of the brain, and this is time. So when you turn on the monitors, they typically present this kind of data. I just wanted to summarize what we've talked about a little bit. We've talked about the suppression ratio, this scale from 0 to 100. We've talked about the spectral edge. We didn't mention EMG, but EMG is a measure of how much muscle activity there is between the electrode and the skull. And if there's a lot of this number becomes difficult to interpret. So let's go on to the 5 reasons. Reason number 1. I like to say this a lot. Why go blind when you can see? If the target organ of anesthetic drugs is the brain, we should be interested in monitoring the brain. What the EEG does is it provides us an electrical signature of the brain in real time. Things I think we should know. We should know basic waveform morphology as mentioned, awake versus general versus burst suppression versus isoelectricity. We should be able to identify the suppression ratio. And we should be able to pick out the alpha band and look at the amplitude. Second reason for using a process EEG is the clinical scenario where you're taking care of a patient that may have a vulnerable brain. This is a term that is perhaps evolving in terms of what it means. My take on what I've gathered from the literature is that it's a description of patients who may exhibit increased sensitivity to anesthetics and or may develop adverse neurocognitive effects following an anesthetic. Who these people are, advanced age, probably the age cutoff nowadays is, in terms of these kinds of things, is 60, 65. History of neurovascular disease, intracranial pathology, traumatic brain injury, or overwhelming infectious or metabolic derangements. Vulnerable brain. Probably a good idea to monitor these people. Let's go over some of the published work in this space. Using process EEG guided anesthetic titration, looking at some clinical outcomes of interest. And I've listed them here. Postoperative delirium, postoperative cognitive dysfunction, awareness, mortality. Several randomized control trials have explored the incidence of delirium and cognitive dysfunction. My assessment of that literature is the results are varied. They're difficult to distill out the clinical directives that have a consistent, and it's hard to make sense of what the clinical directives are and how we are to interpret them. For example, in patients over the age of 60, some trials found that using EEG-guided anesthesia reduced postoperative delirium, while others did not. Only one study found a decrease in the incidence of postoperative cognitive dysfunction, while others didn't. Perhaps one of the hallmark articles in this, it comes to us from JAMA. It's entitled The ENGAGES Randomized Clinical Trial, and ENGAGE is an acronym for all of this, EEG-guided anesthesia administration on postoperative delirium. And in this study, they compared the process EEG-guided target of BISA 40 with routine anesthesia. And they looked at whether it had an impact on postoperative delirium. And they found that the process EEG-guided anesthesia did not decrease the incidence of postop delirium, but it did do a few other things. It led to a very modest 0.8 to 0.7 reduction in anesthetic exposure. it decreased the duration of EEG suppression. How they looked at that was BIS less than 40. And it went from 60 minutes to 32 minutes. And then they looked at the time the suppression ratio is greater than 0. In this case, greater than 1%. And it was 7 minutes total time in the EEG titrated versus 13 minutes with no form of titration. And this came out a couple of years ago and caused quite a stir, especially for people who were very pro process EEG guided anesthetics. And in fact, a group published an independent discussion of the data reported in the Engages trial. And this is prepared by Ackland and Pryor. And in this study, in this interpretation of the analysis, they make the following points. And it's all around the suppression ratio. Prior work has established that the suppression ratio in the presence of low anesthesia has a higher incidence of POD. And so what they were saying is that in the Engages trial, there may have been people who had low anesthesia and evidence of burst suppression in both groups. So how could they really differentiate the influence of process EEG monitoring? They also identified that the published threshold for an increased risk in postoperative delirium is a duration of burst suppression of 4 minutes or more. And I want to remind you that in the Engages trial, the burst suppression was 7 and 13 minutes between the two groups. And they're saying that prior data says that if you're longer than 4, you're at risk for having POD. So again, it calls into question the interpretation of the Engages trial data offered by the authors of that trial. They point out that the duration of both groups in the Engages exceeded the threshold values found previously to be associated with a marked increased risk of delirium. And they say it's difficult to draw any conclusions about the utility of PEG-guided anesthesia delivery on reducing the incidence of POD. In another meta-analysis done by McKinsey et al., they looked at 5 randomized controlled trials with over 2,600 patients. And they found that the use of a process EEG monitor was associated with a 38% reduction in the odds of developing postoperative delirium, but that there was insufficient data to explore the use of process EEG monitoring in postoperative cognitive dysfunction. Dr. Shao and company recently published this paper, which I thought was a real interesting concept. Its title is Low Frontal Alpha Power is Associated with the Propensity for Burst Suppression on EEG Phenotype for a Vulnerable Brain. So let's take a look at some of the stuff they did. They looked at patients that were maintained with either propofol or sevoflurane. They characterized the relationship between burst suppression and alpha power. Remember the amplitude of that alpha band. And they used some logistic regression, and they found that for every decibel decrease in the frontal alpha power, the odds of experiencing burst suppression increased by 1.33. They propose that their findings represent an EEG phenotype of a vulnerable brain. And other folks have looked at this too, and the way they've looked at it is they've done mini cognitive exams before surgery and mapped burst suppression and low alpha power to the folks that had cognitive deficits before surgery. So here's what it looks like. Here are 2 examples of spectral displays, one with high alpha power and one with low. Now, to remind everybody, that alpha power is that frequency band between 8 and 12 hertz. Remember, like right where this red is. So Red is warm color, high amplitude, between 8 and 12 hertz. This looks like a really solid, healthy brain to me. Okay, here's another one between 8 and 12 hertz. Here's our alpha band right through here. And it's blues and greens, so much lower power. Remember, this is a logarithmic scale, so there's huge amplitudes and not so big in here. And then they also noticed on the raw EEG some burst suppression here. So this is what I would say is a sicker brain. And I think being able to calibrate our eye to these spectral displays will help us be more rigorous in how we titrate anesthetics to things that matter. And perhaps that's the piece that's missing for us, because what matters is how the patient does after they wake up. And frankly, after they wake up, they're off our radar screen. We don't look in on them and check how their brain function is. We're not familiar with the tools on how to do that. And cognitive dysfunction can happen days and weeks afterwards. And I think it's high time we start looking into that. And this is perhaps a tool to help calibrate us on how we can approach people who have a vulnerable brain and adjust the titrating our anesthetics accordingly. Okay, so we've done 2 reasons so far. We got 3 to go. The first one was why go blind when you can see? Learn the stuff you need to learn about process EEG monitoring and use it. Second one was the vulnerable brain. The third reason, total intravenous anesthesia and neuromuscular blockade and the risk of awareness. So to get us started, I'd like to kick off with the BAG recall clinical trial. And it's a prospective, multi-center, randomized, controlled trial to determine whether BIS-guided protocol is superior to anesthesia gas-guided protocol in reducing intraoperative awareness. And there have been several studies like this. BAG recall, Be Unaware, the Michigan Awareness Control Study. All of them found that a BIS protocol was not superior to end-tidal anesthetic-guided anesthesia. And the current evidence endorses the use of end-tidal anesthetic concentration alarm to prevent intraoperative awareness. Well, that's all fine and good if you use inhalation agent, but what about for TIVA? In 2014, the 5th National Audit Project, NAP5, sponsored by the Royal College of Anaesthetists and the Association of Anaesthetists of Great Britain and Ireland, they did a retrospective observational study of over 2.8 million patient records during a 12-month period. And they found the incidence of accidental awareness as spontaneously reported by patients was 147 of the 2.8 million, or 0.0005%. Very low. But they also found that the incidence of awareness was different based on anesthetic technique. NAP report emphasized that TIVA had a higher rate of awareness compared to general anesthesia. And it was even higher when there was a neuromuscular blockade drug involved. The incidence of awareness with neuromuscular blockade was 0.012% and without it 0.0007%. TIVA in combination with neuromuscular blockade appears to give the greatest risk of awareness during general anesthesia. So it's the bad combo for awareness, TIVA plus neuromuscular blockade. So the authors of the NAP5, they recommended that process EEG monitor may have a protective effect against awareness during GA, during general anesthesia, when using these 2 drugs. In a different study conducted by Arando et al., they did a prospective observational study with structured interviews blinded to anesthetic technique. And they compared inhalation agents to TIVA. And they did their interviews in the PACU. They looked at 4,000 patients with 42 anesthetic care providers. The overall incidence of awareness was 1% and 0.6 in elective procedures. When TIVA was involved, it was slightly higher, 1.1% than when it was an inhalation technique. So this drives home the idea that TIVA may have a higher risk of awareness. And I think the driver there is that TIVA requires a free-flowing IV, requires that the drug be running the whole time, and that we look at it, and there is no alarm system available to confirm that we're giving drug, as there is with end-tidal agents. So I think the bottom line is we should use process G monitoring when using TIVA combined with a neuromuscular blocking agent to minimize the risk of awareness. Without a neuromuscular blocking agent, it's a lot better because the patient will probably move before they have awareness, so that will trigger a response from you. Reason number 4, management for changes in hemodynamics. I'd like you to consider 2 clinical scenarios that you may encounter. One is the blood pressure is low. And without process EEG monitoring, you have 2 possible things that are wrong. One, it's low because you have too much anesthesia, or another one is that you have a person who's cardiovascularly impaired and just with a normal amount of anesthesia can't maintain a reasonable blood pressure. How will you know unless you know what the brain's doing? If you're able to monitor the brain, you can discriminate between these 2, and that might drive how you would take care of it. For example, if the pressure is low and the process EEG indice is normal, say a BIS of 45, you may not turn down the anesthesia, but reach for a vasoactive agent instead. But if the pressure is low and the process EEG indice is also low, say a BIS of 15 or 20, then you're more likely to want to turn the anesthetic down because you're probably overdoing it. The same holds for a high blood pressure. If you have a patient that has a high blood pressure but a normal indice value, normal BIS value, then you probably reach for an antihypertensive. If, on the other hand, if they are hypertensive and their BIS value is high, then they need more anesthesia. So the take-home here is a more informed approach to managing adverse hemodynamic changes that we encounter in the operating room. And finally, to take us home, reason number 5, known or anticipated large blood loss. And to illustrate this, I'd like to briefly go through a case report published by none other than our chair, Dr. Egan, along with some other folks. And this case report's kind of interesting. The patient was having major vascular surgery. It was a TIVA with a target-controlled infusion. They had an A-line because they wanted to, of course, have beat-to-beat monitoring of this patient during a major vascular surgery, but they also wanted to measure blood propofol concentrations as part of a study. They were also monitoring the BIS, and they noticed that it was around 35. They weren't targeting a BIS level. During the case, the patient was hemodynamically stable. After they placed an aortic graft, they took a cross clamp off, and it was on for about 60 minutes. After unclamping, taking the clamp off, the BIS monitor dropped into the 20s. The heart rate and blood pressure remained stable for the next 10 minutes. Then, 10 minutes later, the blood pressure dropped from 120/70 to 65/30. Here's a figure of what's going on. So here's time on the x-axis, the arrow is the cross clamp. Here's our mean arterial blood pressure going along, And here's the bispectral index. Clamp comes off, index drops. 10 minutes later, multiple blood pressure measurements later, the pressure drops. So this is an example of how hemodynamic instability is picked up pretty quickly with process EEG monitoring. They also managed to measure some propofol concentrations, and their target concentrations at these time windows, pre-induction, cross-clamp, after induction, were 0, 5, and 3 respectively. Check out what the measured propofol concentrations were. Well, 0 and 0, that makes sense. 4.71 with a target of 5, that's in the ballpark. But look what happens. They measured, their target was 3 when the BIS fell, and the measured was more than double. And I think this gives an example of when people suffer, it turns out that the patient suffered some severe blood loss and ultimately didn't make it. I think the take home here is that when there is a lot of blood loss, the body becomes a heart-brain pump, and any drug that we put into it doesn't get distributed, perhaps doesn't get as metabolized as quickly, and so much, much less drug is needed to get the same effect. And in this case, the target control infusion at 3, assuming normal distribution, was dramatically altered and ended up in very, very high concentrations because the distribution was dramatically altered because the cardiac output had likely dropped. I'd just like to end this by pointing out that a group of experts in process EEG monitoring recently got together and prepared a consensus statement. A summary of that consensus statement is probably worth taking a look at. And just running through each of these really quickly, we recommend that clinicians consider using EEG monitoring to inform anesthetic management. To be knowledgeable in EEG interpretation, that raw waveform, the spectrogram, process EEG indices. The use of end-tidal anesthetic gas monitoring with alarms, or process EEG monitoring, for example, with TIVA, to minimize the risk of awareness. We recommend the use of process EEG monitoring to reduce the risk of awareness with recall in patients with total intravenous anesthesia. There's insufficient evidence to recommend using process EEG monitoring in older, high-risk patients undergoing general anesthesia to reduce the risk of delirium. I would suggest to you that in patients that have a vulnerable brain, it may be useful. We recommend clinicians consider using EEG monitoring to detect unintended burst suppression during general anesthesia. So again, we need to know what that is and where to measure it and how to look at it. And there's insufficient evidence to make recommendations on the use and the process of decrease the risk of postoperative neurocognitive disorders in older patients having major non-cardiac surgery. So I think these consensus statements they're good to look at. I think the take-homes here are, it's reasonable to expect of us as anesthesiologists to have a working knowledge of process EEG, the raw EEG, how the EEG changes, awake versus general, knowing when the EEG is showing signs of brain strain, if you will, with burst suppression and isoelectricity, knowing where to look on the monitor to detect that burst suppression, knowing where to look to see a decrease in the alpha frequency band power, and making adjustments as needed. Thanks for listening to my 5 reasons on why you should consider using process EEG monitoring. I hope you've found it helpful, and I'm happy to take any comments or questions based on these points we've covered. Thank you very much.